for inviting myself as well as my colleagues Marco Cacamo and George Sokos to present today. So our presentation is entitled, It's 2020, Let's Practice Like It, Contemporary Heart Failure Management. So to start off with disclosures, we all do receive research grants from AstraZeneca for the DELIVER trial as well as Sanofi for the SOLOIST trial. These are both SGLT2 inhibitor trials and heart failure, which I'll touch upon briefly. Failure hospitalizations. He presents now for a 6-month follow-up with you.
Yes, which one?
He's extremely well. He reports essentially NYHA 2 functional class. He's an ACC stage C heart failure with an ejection fraction now of 30%. Pertinent findings on his physical exam are a heart rate of 78 beats per minute with a blood pressure of 110/75 and a BMI of 32. Available labs include a normal sodium at 135, a BUN of 28, a serum creatinine of 1.4 for a GFR of just shy of 70. His LDL is 80, his hemoglobin A1C is 5.2. He has a mildly elevated BNP at 260. His ECG is normal sinus rhythm at 78 beats per minute with a narrow QRS. His current medication regimen includes metoprolol succinate at 100 milligrams daily, lisinopril at 10 milligrams daily, aspirin, ticagrelor, as well as a high dose or high intensity atorvastatin. And we'll come back to that patient here shortly. So to start with, I want to just touch on historical guideline directed medical therapy. And so essentially what we've had in heart failure for the last several years. So there are reports of digoxin, Digilef, which you can see pictured there, that actually date back to the Egyptians, but at least in modern medical literature, William Withering is really credited as one of the first physicians to take advantage of the positive inotropic therapy that may be afforded by Digilef. This is a picture I actually took myself in rural Pennsylvania at my wife's family farm. This grows freely there. Then in the early 1920s, the introduction of the first diuretics. In the 1980s, we get to 1981, the first ACE inhibitor, captopril, was FDA approved. And then you see there this New England Journal publication in June of 1987, the consensus trial, one of the first large-scale heart failure trials, truly, but to demonstrate the benefit of ACE inhibitor in that particular study was enalapril in patients with congestive heart failure. In 1993, we have the MDC trial, the metoprolol and dilated cardiomyopathy trial that was published in the Lancet. This was a groundbreaking trial at the time. It was thought to be heresy to use beta blockers in heart failure with reduced ejection fraction leading up until that time. But these pioneers and others did demonstrate the beneficial effects of beta blocker therapy. And then in 1999, we have the publication of the RAILS trial, again in New England Journal by Bertram Pitt, which was a trial that demonstrated the positive effects of aldactone in patients with advanced functional class heart failure with reduced ejection fraction. Subsequently, the emphasis trial was published that similarly showed benefits of MRAs in less significantly symptomatic heart failure with reduced ejection fraction patients. So that was basically it until the 2000s. Let's examine a bit of how well even this GDMT has been used and is used currently. So this is data from the CHAMP-HF registry, which is a large contemporary registry. This publication is one that should essentially represent the way that heart failure with reduced ejection fraction is treated in the United States with contemporary management. And I know we didn't get to the ARNIs yet, but if we just look at whether a patient was on an ACE inhibitor, an ARB, or an ARNI, unfortunately, even with this old data, only 72% of patients in this registry were on one of those agents. Beta blocker, just shy of 70%. And MRA, unfortunately, only about a third of patients were on therapy. So what about dosing of this guideline-directed medical therapy? You know, we know there are certain target doses of these therapies that patients were meant to achieve in the large-scale clinical trial that led to their FDA approval. So how do we actually do at dose titration over time? So this is the same data set from CHAMP registry. And you can see here in the gray depicting they're not on the medication, and I guess you could say the dark orange, they're on less than half of the target dose, yellow being they're on 50 and 99% of the target dose, and then the green being they're actually truly on the target dose of the medication. You can see ACE inhibitors or ARNIs, we're dealing with only about 10% of people truly being on the target dose of medications. Another really disturbing thing that comes from this data set is that you can see the dose titration over time. So at baseline, 3 months, 6 months, 9 months, and 12 months. And unfortunately, the fact is that truly we do a poor job as a medical community of trying to up titrate the doses of these medications to represent or to simulate what was done in the large-scale clinical trials. And unfortunately, you see there's both an underutilization and certainly an underutilization in target doses and poor medical up titration of therapy. Likewise, beta blocker therapy, only just over 20% of patients on target doses. And again, we really don't see significant up titration over time. MRAs similarly. So at the end of 12 months in this data set, the red you can see is patients that are on stable sub-target doses or not even on the medication. The green being stable target doses, the doses that we want to try to achieve. The blue being at least we started them and tried to increase them. And then the yellow being either had to stop the medicine or decrease the dose. You can see, unfortunately, our ability to really introduce and up titrate these medications to target doses is unfortunately quite poor. And I think that this is something that we can all do a better job of, just using the basic medications that I described that were, really proven to work in heart failure since about the 1980s to the early 2000s, obviously with the exception of ARNI. So what's new in heart failure with reduced ejection fraction? Well, there are several new things in the field related to medical therapy as well as device therapy. We're not going to get into device therapy today, but that's another topic unto itself. And we're going to speak just about medical therapy that's new.
Good morning, everybody, and welcome to Grand Rounds. I want to thank you all for inviting our team to present to you on some newer heart failure therapies. I am, very honored to be talking about this with you all. Really good to talk to you about two newer agents, one of which is not quite as new. I know most of you are familiar with the angiotensin receptor neprilysin inhibitors, or ARNIs, or sacubitril valsartan. And the SGLT2, or sodium glucose cotransport 2 inhibitors. We're talking about how these drugs are utilized in heart failure. So I'm going to try to talk about a little bit about the mechanism of action and why they chose these medications for these trials, kind of and some of the outcomes, important outcomes of these landmark trials. So when you look at sacubitril valsartan, or when it was actually studied and when the paper came out was LCZ 696, let's look at the mechanism of action, because I think, there's two sides to this. We know the angiotensin receptor blockade, or the valsartan portion of this medication. Those trials go way back. So if you start looking at ACE inhibition, those go back to the late 80s. And why do we look at those? Because we know that when we block the RAS system, we see a reduction in sodium retention, volume expansion. We see less vasoconstriction, less myocardial fibrosis, and myocardial hypertrophy, which in return results in improved mortality. So you can understand why you're going after that pathway, and that's where the valsartan comes in. And neprilysin inhibition, they did that back in the 90s as well. Didn't see a benefit back then, but they looked at it necessarily with ACE inhibitors, and then really didn't see a benefit. But when they looked at it now, they want to say, okay, let's put it in conjunction with an ARB. You want to go further down on the pathway, because if you think about if you have neprilysin inhibition, you see the increase, sometimes an increase in angiotensin 1 and 2, which is why they think using neprilysin alone or with an ACE inhibitor wasn't necessarily far enough down the pathway. So when you look at an angiotensin receptor blocker, you block that potentially detrimental portion of the medication. But with the neprilysin inhibition, you see an increase in natriuretic peptides and natriuresis and diuresis, and you get vasodilatation as well. So you get an enhanced effect of blood pressure reduction and afterload reduction, as well as an enhanced effect of diuresis, which can affect what you do with some of your other medications. So just keep that in mind. So again, you look at the effects of the neprilysin inhibition, which we just talked about. You get a decrease in neurohormonal activation, vascular tone, fibrosis, and hypertrophy, and sodium retention. You reduce all of those. So what do we look at? So when you think about the landmark trial, this is almost 6 years ago now, so I don't think that it's actually that new, but again, it's not necessarily as utilized in practice as much as we'd like it to be, based on some of the newest guidelines from the HA and ACC. So it's not me, that's the national societies discussing with guideline therapy. So Paradigm HF was the landmark trial, and it really compared sacubitril valsartan at 97,103 versus enalapril at 10 BID. And it was specifically designed to replace ACE or ARBs as the cornerstone of treatment in heart failure. So really big trial. They included folks with class 2 to 4 heart failure, EFs less than 40% originally, did admit it down to 35% because of some of the outcomes. A BNP greater than 150 or an NT-proBNP greater than 600, somewhat lower if they were hospitalized in the last 12 months. They had to be on a stable dose of an ACE or an ARB equivalent to 10 milligrams of enalapril daily for at least 4 weeks. They had to be on a stable dose of beta blocker for greater than or equal to 4 weeks unless that was contraindicated. Have a systolic blood pressure of about over 95, and a GFR greater than 30 with a potassium less than 5.4. You had a single blind run-in period where over 10,000 patients were started on enalapril 10 milligrams twice daily, changed to sacubitril valsartan at 49.51 to 97.103 over 46 weeks, and then you ended up with about 8,400 patients that were divided between enalapril 10 milligrams BID and sacubitril valsartan 97.103 BID. And that was a 34-month follow-up. The study was stopped early at 27 months because of the benefit of the sacubitril valsartan, and we're going to go over what that really meant. But the primary endpoint was death from cardiovascular causes or hospitalization for heart failure. Again, primary endpoint of cardiovascular death or heart failure, you saw a significant reduction in the events at 21.8% with the sacubitril valsartan versus 26.5% of enalapril in the enalapril group. Importantly, I think you see a benefit that was seen early and lasted throughout, and only widened as the trial went on. So the early benefits seen here, and they're really important to think about that. You don't need to use it that long to see the benefit, and you only need to treat 21 patients to see that benefit. I think another important part of the trials is that when you break down the primary endpoints components, cardiovascular death or hospitalization, neither one of these actually drove the significance of the primary outcome. So you did see a statistically significant reduction in both of these outcomes. So both cardiovascular death and hospitalization for heart failure. What about all-cause mortality? Again, you did see a benefit in the sacubitril valsartan versus the enalapril. Took a little longer to see that in the all-cause mortality group, but again, it was was a reduction at 17% versus 19.8%. That was statistically significant, excuse me. And the number needed to treat here to see a benefit to all-cause mortality was 36. Really low numbers of patients to see a benefit if you think about that. What about looking at some of the subgroups? You saw really a benefit in all different subgroups. Age really didn't seem to play a role with less or greater than 65 years of age, male or female. You did see more benefit in class 1 or class 2 patients than in class 3 or 4. GFR didn't really play a role. You did see a better benefit in EF less than 35, which really kind of moved us towards amending that protocol where it was reduced to 35% inclusion. These NT-proBNP didn't make a difference. The presence of hypertension. Seemed to see if they were on the ACE prior, it did seem to see a little more benefit that was statistically significant. But ACE or an ARB, or excuse me, an aldosterone antagonist or prior hospitalization really didn't play a role. So I think, one important thing to take away from this is the benefit was seen in all subgroups. You saw benefit in both cardiovascular death and the hospitalization, heart failure hospitalization. One thing to remember about using Entresto, you do get an enhanced diuretic effect, so you may have to adjust the diuretic dose somewhat. I don't do that up front, but you always have to talk to your patients about that, and you may need to think about reducing that at some point in the future. So something to keep in mind. And that goes for the SGLT2 inhibitors, which we're going to talk about now. So you see, now we're going to the SGLT2 inhibitors. They've been shown to reduce the onset of heart failure in patients with type 2 diabetes. And the benefits of SGLT2 inhibitors may be glucose independent and may be beneficial in non-diabetic patients. So if you look at the rationale for using SGLT2 inhibitors to treat heart failure, we know that diabetes and heart failure have similar pathophysiologic features, both have endothelial dysfunction, insulin resistance. The mechanistic effects of SGLT2 inhibitors are seen with patients with and without diabetes. They cause diuretic effects, again with natriuresis and glucosuria, and that's the mechanism. That's how you excrete volume with the glucose in the urine, and you can see metabolic effects. But the benefits may be are largely independent of glucose levels. So really important. So that's why you can look at it in both patients without diabetes as well. So, but again, you have to be careful because you do get a natriuresis and you do see more volume removal, so you may have to adjust your diuretics. Something to keep in mind as we move forward. So let's look at the trial itself. Again, you were in randomized trial looking at dapagliflozin with and without diabetes and low EF patients. About 8,000 patients underwent screening. Half made it to randomization. Over half, about 2,300 were assigned to DAPA group versus 2,300 into placebo, and about similar mechanisms of, similar numbers of discontinuation in both groups. Looking at the primary outcome, you saw a significant benefit of dapagliflozin versus placebo, and you saw a nice trend in reduction in hospitalization for heart failure, as well as cardiovascular causes and death from any cause. So again, your composite endpoint was positive. And if you look at your composite endpoint, really according to some pre-specified subgroups, you really saw benefit no matter the age. Again, if you go back and look at, we think about our sacubitril valsartan group, you saw benefit in age lower or greater than 65, more benefit in men. I think, there's a trend to be beneficial in Black patients in this trial, but there's such a small enrollment of Black patients in this trial that it's hard to see that benefit. That was one of the criticisms of the trial after it was published. But I think we feel that we still strongly use it in our African-American patients. I feel I don't want to deny my patients the benefit based on race, because there was a trend to benefit here. Again, you can see that the geographic region, there's a trend in North America and Europe. A lot of it was driven in Asia and South America. Better benefit in class 2 patients versus the class 3 or 4 patients. Lower EFs tend to prove better, as well as lower NT-proBNP. If they had hospitalized for heart failure, they seem to derive more of a benefit. Well, didn't really make much of a difference with MRAs at baseline. etiology, ischemic or non-ischemic, really didn't make a difference, nor did their body mass index. And so you can see, really the characteristics of the patients, 66 years old in both groups, majority were white. This is what's kind of what we see in our population. So I think it hits home. I look at any trials like, do these patients really fit what I see on a day-to-day basis? And for us, that's a yes. Again, we're not practicing in South America or Europe, but there's a decent amount of patients that were enrolled from the US. The functional class, majority were class 2, which I think is why you saw the trend of the benefit in those patients. Decent blood pressure, EF was about 30% in both groups. Again, majority were ischemic versus non-ischemic. A lot had heart failure hospitalizations primarily, good renal function. Lower amount of device therapy. Again, I think that stems from the lower amount of patients being enrolled from the US. All over 90% on diuretic. And when you combine the ACE, ARB, and sacubitril valsartan, over 96% were on that part of the RAS inhibition. A really good amount of patients on mineralocorticoid receptor antagonists or spironolactone or eplerenone. I think that's a really high number. Low number on DIG, and you see a variety of different other glucose lowering agents. So again, I think to show a benefit on this good of background therapy, very important and very impressive in my mind. Just like sacubitril valsartan was on top of other background therapy. But even here, I think you had a higher number of patients on good heart failure therapy before they even added any of these agents, this agent. So I'm really impressed with the outcome of this trial. We use the SGLT2 inhibitors on a pretty routine basis. Got to be careful with getting them approved with insurance. If you don't have a previous history of diabetes, it makes it much more difficult. Though now that we have trial data to back us up, I think it's becoming easier to get through. And remember, you're going to have to adjust your diuretics at some point because of the natriuresis that you see with these agents. So be careful. Again, you didn't see a significant worsening in the safety outcomes. I think that's really what I want to show on this slide is that you didn't see a significant increase in volume depletion or renal adverse events. But I think, in using it in clinical practice, I want to tell you that you got to be careful with that. You got to watch that. You got to watch your creatinine, even though there really wasn't a significant change there. So be careful. Feel free. I encourage you to utilize these agents. You're going to see these in the guidelines. You're going to see all these therapies. You're going to see either an ARNI, which we would push with the sacubitril valsartan, a beta blocker, a mineralocorticoid receptor antagonist like spironolactone or eplerenone, and you're going to see these SGLT2 inhibitors. So I think these are going to be the cornerstones of therapy, and you're more than likely going to see more metabolic modulation to come in the future, as we know that glucose metabolism does play a role in heart failure. So really happy to be able to talk about these medications, these trials with you, and happy to answer any questions at some point in the future. Sorry we can't be here in person, but I think to take home with the SGLT2 is that we saw a reduction in the worsening heart failure or death from cardiovascular causes in the DAPA group versus the placebo group. So thanks very much, and appreciate your guys' time.
So now I'd like to speak with you more about the drug ababardine. So what's been known for some time now, and these data are from the CHARM trial, although this has been noted in several data sets to date, is that patients with heart failure with reduced ejection fraction who have higher resting heart rates tend to do worse, and those with lower resting heart rates tend to do better, which really brought about the idea, should we or can we reduce patients' resting heart rates, and will that result in improved outcomes? So we know from an epidemiological perspective that those with lower heart rates do better, but how does this actually work, and how may a lower resting heart rate impact cardiac performance? And those of you that have rounded with me know that I really harp on the fact that in the setting of acute decompensated heart failure or a heart failure syndrome, where your ability to augment stroke volume is limited, many times these patients are living off of their heart rate. So their, cardiac output is heart rate times stroke volume. And if you can't really change the stroke volume, they need a fast heart rate to be able to maintain a reasonable cardiac output. Now that's in the decompensated setting, and potentially a very, very minute proportion of patients who have borderline low output heart failure. But in the great majority of patients, this elevated resting heart rate is really a reflection of sympathetic activation and their RAS system. And if somebody is compensated in the ambulatory setting, being afraid to reduce their heart rate is almost like saying being afraid to diurese a patient, because of their heart failure syndrome, they develop some degree of fluid retention, and that has to do with an activated RAS system. Similarly, heart rate goes up, and the same thing, it has to do with an activated RAS and sympathetic system. And we certainly give diuretics because we know that this is initially good response that then turns maladaptive. Similarly, heart rate is the same way. So in the ambulatory setting, we now believe that lowering heart rate can improve outcomes. And at least from a purely cardiac performance perspective, I can explain why that may be. So to start with, we'll talk a little bit about pressure volume loops. This is a complex topic that we're not going to get deep into, but I'll just give some of the basics. So if we start with this graph, this rectangular sort of shape that you see is meant to represent the cardiac cycle, and the width here of this box is meant to represent stroke volume, the difference between end-systole and end-diastole. So the slope of this line, the red line, is the effective arterial elastance slope, and the slope of this line is the end systolic elastance slope. And this determines the end systolic pressure volume relationship. And this angle that we form here really determines essentially the ventricular arterial relationship. So this slope of end systolic elastance can be made to increase in this direction with positive inotropic therapy, or decrease in this direction with poor contractility. We don't really have drugs, oral drugs or ambulatory drugs at least, that we use to impact this slope. So most of our ambulatory drugs really work on trying to impact this slope of effective arterial elastance. So this could be thought of to represent almost total afterload. This slope can be impacted both by it can move in this direction with a reduction in total peripheral resistance, or basically SVR, the same concept, or also heart rate, which is not as well known by many. And basically, if this slope moves in this direction, the width of the stroke volume will increase, so we'll have a higher cardiac output, and also eventually this whole pressure volume loop will start to shift. And whenever this starts to shift in this direction, this turns into a favorable energetic sort of situation, which may positively impact both acute performance as well as energetics of the myocardium. Well, from a purely cardiac performance perspective, if we are able to lower this slope by decreasing the heart rate, you can see the resultant stroke volume that we have widens. And that is one reason why a decrease in heart rate, if you are able to then augment, meaning we can change the width of this stroke volume, can improve cardiac performance. So how does ivabradine do this? So basically, we have multiple different channels that are outside of the scope of this lecture that determine our resting heart rate through the sinoatrial node. One of those channels is the IF channel, the funny channel. So basically, this is a mixed sodium potassium cation channel that, when activated, leads to an inward cation current, so an inward positive current. And that then determines the diastolic depolarization slope. So with inhibition of that IF channel with a selective inhibitor of aperdine, we're able to lower the slope of the diastolic depolarization period, in turn lowering the heart rate. Key to this mechanism is it lowers heart rate without decreasing, at least acutely, without decreasing inotropy or contractility, which is different from beta blockers. So, how was this therapy evaluated and proven? So this is the SHIFT trial, which was published in Lancet in 2010. The idea to evaluate whether heart rate slowing with rapidine improves cardiovascular outcomes and symptoms in patients with moderate to severe, meaning NYHA class 2 to 4 functional class, with heart failure with reduced ejection fraction to less than 35%, who have a resting heart rate of over 70 beats per minute in sinus rhythm and were receiving guideline-directed medical therapy, which included maximally tolerated or guideline target doses of beta blockers. So the primary input of the trial was a composite of cardiovascular death or first hospitalization. And as you can see in the curves here, with the use of irapardine, we have a reduction of 18% in that composite endpoint for a number needed to treat of 26. If we look at each of the outcomes in more detail, the primary outcome I showed you, significantly lower in the irapardine group. Now that was a primary composite outcome, and it was in truth driven by first hospitalization for heart failure. If we just look at cardiovascular death, there was no significant improvement with the use of irapardine in this trial. First hospitalization for worsening heart failure was reduced, not shown in this slide, as was second hospitalization or even third hospitalization for heart failure during this trial. All hospitalizations for worsening of heart failure, as well as cardiovascular hospitalizations. So what were the major adverse drug reactions that were seen in the SHIFT trial? So number one was bradycardia, with a significantly higher rate in the ivapridine group, which is not surprising at all, as that's what the drug is meant to do. Hypertension, actually, there was a statistically significant increase in blood pressure that was seen with the use of rapidine, which some look at as probably a positive signal of increased cardiac output. There was, in fact, an increased incidence of atrial fibrillation, which is why we don't necessarily use this drug, or at least from a guideline-directed medical therapy perspective, in patients with atrial fibrillation. And then finally, phosphines, which is a unique side effect that we see with ivapridine, which is basically these spots of bright light are seen as there are parts in the eye that actually also have channels similar to the funny channel, which are impacted potentially by this drug. So that was seen in just shy of 3% of patients. So these are the curves that show the outcomes for cardiovascular death, which I already told you were similar and not statistically significant between the two groups. But if we look at patients with death from heart failure, there was a significant difference between ivapridine from placebo. Also, if we look at the baseline heart rate of patients, I mentioned that the trial inclusion criteria required a resting heart rate of greater than 70. If we just look at those that had a resting heart rate of greater than 75, all of a sudden there is a statistically significant improvement in cardiovascular death with the use of rapidine. Granted, this is post-hoc analysis, but there's the data, be it what it may. If we look at those that received ivabradine and look at their outcomes by the heart rate they were able to achieve by the end of essentially the first month, we do see that the patients in a kind of dose-like relationship, the patients that were able to achieve lower heart rates had incrementally fewer CV death or first hospitalization outcomes. Similarly, or additionally, I guess I should say, if we look at the ECHO sub-study from the SHIFT trial, we see significant improvements. So more patients on ivabradine were able to have an improvement in their ejection fraction and a reduction in their LV end systolic volume. It's kind of showing that these drugs, by reducing the heart rate over time, can lead to positive remodeling effects on the ventricles. So these data and others led to the approval of ivabradine in 2015. It was FDA approved. Patients in sinus rhythm with a resting heart rate of greater than 70 beats a minute on maximally tolerated beta blockers, or those who have a contraindication to beta blocker use. And we see in our most recent guidelines, ivabradine does receive a 2A recommendation for use in patients with heart failure with reduced ejection fraction that have the characteristics I mentioned earlier.
About Vericiguat today, which is a novel soluble guanate cyclase agonist. So a little bit of background. So in terms of heart failure, the vascular endothelium normally generates nitric oxide, which stimulates soluble guanate cyclase, and it's mediated cyclic guanosine monophosphate production. Endocardial endothelium is also sensitive to nitric oxide and regulates contractility and diastolic dysfunction by raising intracellular cGMP. And this process becomes very dysregulated in heart failure. About Vericiguat, it's a soluble guanate cyclase stimulator. It's actually not the first one used this is another generation, and it augments soluble guanylyl cyclase activation induced by nitric oxide. But unlike your typical nitrovasodilators, it does not induce tolerance with long-term administration. So that's very important in the heart failure world, because a lot of these nitrates, you develop tolerance and can be a problem long-term. And soluble guanate cyclase activity is stimulated independent of nitric oxide. So nitric oxide does not have to be present to catalyze this reaction. So it works independently of nitric oxide, which makes it a more potent vasodilator than any of the other drugs, such as phosphodiesterase type 5 inhibitors. So a little bit more about Vericiguat in the background. It was in a phase 2 trial called the Socrates Reduced. Higher doses of Vericiguat resulted in a reduction in NT-proBNP from baseline to week 12 on secondary analysis. The primary outcome, however, was neutral, so they felt they needed more power, so they enrolled more patients, enrolled this in a longer continuum, and this was the prequel to the Victoria trial. Also note, one thing they saw, which was harmful, patients with pre-existing lung disease, in particular pulmonary fibrosis, had a worse outcome. And one of the exclusion criteria for Victoria was pre-existing lung disease. So very important that these drugs can be beneficial, very harmful with patients with pre-existing lung disease, in particular pulmonary fibrosis. So it's always important to know who funded the study. Obviously there can be biases inherent when it's funded by pharma, and this indeed was funded by Merck and Bayer. It's a phase 3 randomized double-blind placebo-controlled trial, so very rigorous. Approximately 5,000 patients with heart failure class 2 to 4 symptoms and an EF less than 45%. So a pretty good sick population. You have class 2 patients kind of walkie-talkie, not significantly limited, but then you have the sicker patients, and that's really what they recruited. And the primary outcome was a composite of death from CV causes or first hospitalization for heart failure. And patients were randomly assigned to the soluble guanate cyclase stimulator Vericiguat or placebo, in addition to guideline-based medical therapy. And as we talk a little bit later, this was a paper that was published in New England Journal in May 2020. But one caveat to it is guideline-based medical therapy can mean many different things. And as you can see, one of the flaws in the study we'll get to is what they decided to be optimal medical therapy. Here's a characteristic of the patient at baseline. And I always want to look at, does this reflect my particular heart failure patient population? So you can see the mean age was 67. So yeah, the elderly are mostly targeted for heart failure, and those are the majority of my patients. So Medicare age patients are what I mainly see. Gender, there is always, in end-stage heart failure or severe heart failure, there tends to be a male predominance, but this one was a little bit skewed where the majority of patients were male. White race was 2/3 of them. However, Asian, 22%, a little bit, obviously elevated in this area, so a little bit misrepresented for my patient population, and only about 5% Black population, so probably see that a little bit higher in other trials. So definitely predominance in white, 2/3, and then representing a low Black population. So for North America, underrepresented, in my opinion. And you can see that when it's broken down by geographic region. The majority of patients enrolled were either from Eastern or Western Europe. You combine those two, that's 50% of the patients. And then Asia Pacific is another 20-30%. That's where you get the large Asian population. And only North America, only 11% were representing the patient population. So very, very underrepresented, which can have an effect. And what they did in the study as well, they broke out the index events by hospitalization for heart failure in previous 3 months. They wanted that to be about 2/3. They achieved that. And the hospitalization for heart failure in previous 3 to 6 months, they wanted less than 20%. They achieved that as well. And then getting IV diuretic for heart failure without a hospitalization the previous 3 months. So that's if they were in clinic, got some IV Lasix in the previous 3 months, or went to the ER, got Lasix, and subsequently discharged and not admitted. And they were going after a very sick, recent population. That's why you see the index event, hospitalization for heart failure in the previous 3 months. That's telling you they just had a heart failure hospitalization. So they're at risk to be readmitted, tend to be sicker. Where they're making it out past 6 months, they tend to be less sick because they become more compensated and stable. Another key thing, EF at the time of screening was on average about 29%. And that we'll make sense of that later on. And obviously the majority of patients had an EF less than 40%. And the majority of patients were class 2 and 3. And that's basically what you see in other trials, a large patient population of 2 and 3. Class 4, very underrepresented because it's a very sick population, too sick. But the reason why they're going after sicker patients, more events. More events can get you to your study results quicker and tend to have a better benefit. So the sicker patients you get, the more benefit you can show. So that's why they really wanted a heart failure hospitalization in the previous 3 months, and you can see that. And here's the graph. So what you see is in graph A, this is the primary outcome, which was heart failure, hospitalization, or CV death combined. And as you can see, it's blown up in the upper right corner where it goes from 0 to 0.55, just to blow it up so you can see the difference in curves a little bit easier. And as you can see, Vari-Sequat had less of the primary endpoint, which is a good thing. They had less death from CV causes and less hospitalization for heart failure. So when you combine those two, the cumulative incidence was lower in the Vari-Sequat at 32 months since randomization. And then you look at death from CV causes. Once again, there's a difference, but the hazard ratio is 0.93, so a little bit higher and not as significant. The bang for the buck they got really was the hospitalization for heart failure. So as it's blown up, as you can see in column C, in graph C, placebo had more hospitalizations for heart failure than Vari-Sequat. But remember, this is a population that was majority outside the U.S. So maybe the reasons for hospitalization for heart failure are a little bit different there as opposed to it is here. And they had to have defined criteria that defined a heart failure hospitalization, but maybe in different areas of the world, maybe they go to the ER less, maybe they go to the hospital less because of constraints. So it kind of gives me a little bit of pause when I look at this data. When you look at picture D with graph D, death from any cause or hospitalization for heart failure, that's all comers. And then again, any cause of death or heart failure, there was benefit with Vericiguat over placebo. So in summary, kind of the Victoria was a very sick population, sicker than most other trials. They had a higher baseline BNP level than most trials. The BNP levels are 300 to 500. When there was Entresto, they had to use a pro-BNP, and once again, those were much higher than average pro-BNPs in other studies. So definitely a sick population. They definitely did that to get more events. There's evidence of worsening heart failure with these patients. As mentioned before, this is a sick population. The hospitalization happened within 3 months of being randomized, 2/3 of the patients. And then they had patients hospitalized 3 to 6 months before randomized. So again, less sick. And they didn't want more than 20% because again, they wanted events. And then obviously there was a sect of patients that had IV direct therapy in clinic or ER without hospitalizations within 3 months. So again, sick population, very symptomatic. They were enrolling functional class 2, but remember, they're at one point functional class 3 or 4 because they got diuretics. So in conclusion, over a median of 10.8 months, there was a 10% reduction in the primary endpoint. The greater benefit was seen in patients aged less than 75 years old, EF less than 40%, CKD stage 3, and patients not on an ARNI and NYHA class 3 and 4. So sicker patients not on Entresto with some kidney disease, they did better and were aged less than 75 years old. And in particular, patients greater than 40% of the patients in this study had stage 3 chronic kidney disease. And that confers a cardiorenal benefit in this high risk population, because the most difficult patients are the ones that have cardiorenal syndrome, elevated creatinines, and makes it tough to treat. But not so fast. Some of the criticism that I looked at with this trial, of course, the background therapies and all those, really a lot of the chunk of the data that really need to be criticized is usually now buried in the appendix. And in this trial, this wasn't any different. Buried in the appendix is the background therapy when enrolled. Screening was occurring between September 2016 and December 2018. And the majority of patients were on good therapy, better than any of the therapies we've done in the past. ACE and ARB, 73%, beta blocker, 93%, MRAs, such as aldactone and perorinone, those are your mineralocorticoid receptor antagonists, 70%. However, your ARNIs, your Entresto, subcutrel agents, only 14%. And this study was between 2016 and 2018. Paradigm was in 2014. So 2 years had lapsed. The data was very strong to use ARNIs, but yet only 14% were on Entresto. And that might reflect Europe, Asia, and so forth. Maybe because the drug was too expensive, they weren't on it. So not really reflecting real life data that we have now. AICDs, the average EF 29%, the majority should have had a defibrillator. Only a quarter did. So when there was CV deaths, were they setting cardiac deaths? Where maybe this drug would have played an important role, where having an AICD, that would have dropped the CV event rate. So didn't even have an AICD. And 15% had BiV permanent pacemakers without an AICD. So really an underrepresented utilization of defibrillators. You see that in Europe and so forth. Definitely less utilization of defibrillators than we do here. So truly not on, in my opinion, maximal medical therapy. And here you look at the different agents, reduction in all-cause mortality versus placebo. Really beta blockers is your strongest reduction in all-cause mortality. ACE inhibitors and MRAs are kind of second and third place. In fact, we underutilize mineralocorticoid receptor antagonists, but yet they have a profound reduction in mortality. And then if you look at all-cause mortality, and these are all single agents. Then when you look at reduction all-cause mortality versus placebo on standard background therapy, when you look at hydralazine and isosorbide dinitrate in the African-American population, a marked relative risk reduction, in addition to standard goal-directed therapies. And that was your AHAF study. Then you had this shift study with ivabradine, about 10% reduction. That's where vericiguat was even less than that, 5% reduction. So not a big bang for the buck for that drug. When you look at ARNIs, such as with Paradigm and Entresto, that was previously discussed, greater than 15% relative risk reduction. And the SGL2 inhibitors, DAPA trial and so forth, greater than 15% reduction. So out of all the agents, vericiguat did the least amount in reduction in all-cause mortality versus placebo on standard background therapy, albeit it was a sicker population. So in conclusion, among patients with high-risk heart failure, the incidence of death from cardiovascular causes or hospitalization for heart failure was lower among those who received vericiguat than among those who received placebo. And really, from real-world standpoint, when I put on my kind of heart failure hat, due to patient compliance and physician underutilization based on Get With The Guidelines data, it would be tough to institute quintuple therapy. And by the Get to Guidelines data, you're talking about, and it was previously discussed, you're talking about 50% of these drugs are being utilized at goal-directed kind of optimal medical therapy. So if you had someone on quintuple therapy, you have an ACE, ARB, or ARNI, such as Entresto, MRA like aldactone, you have a beta blocker on, and you have vericiguat, and you got SGL2 T2 inhibitor on board. 5 drugs, that's a lot for a patient to take when they barely can do 50%. So a really tough thing. And then if you add their African-American population, you're adding hydralazine. Obviously, you can't add a nitrate with the soluble guanine cyclase, vericiguat, but very difficult 5 drugs for one patient to take. But an interesting question I think will be more important is if patients are on an RNA, such as Entresto and other therapies at maximum dose, does vericiguat still offer that same benefit as it did in the Victoria trial? I'm not as optimistic that's the case. And what's the cost? To wait FDA approval. And what's the optimal strategy to adding all these meds? So do you add carvedilol first? Do you add Entresto second? Do you add aldactone third? Like, what is your order of adding all these drugs together? And in our clinic, we really do it based on patients' profile. If they're really sick, we try to go after afterload first because the beta blockers can worsen their heart failure. Then we do the aldactone and then add beta blocker. But if they have lots of blood pressure room doing great, then we'll add beta blocker early. But there is truly an art to making optimal strategy with all these drugs. So if you're dealing with 5 drugs, how do you add these in all order? And that concludes my portion. I'd like to thank everyone for inviting us here, and have a good day.
So now that brings us to, what does this all mean? We have these new drugs. Should we be using them? How should we be using them? When should we be using them? Let's go back to our case of our 55-year-old with ischemic cardiomyopathy following an LAD infarct, who presents to you in follow-up with an ejection fraction of 30%, relatively well, NYHA2 functional class, ACC stage C. With these characteristics on the medications of metoprolol, succinate 100 milligrams, lisinopril 10 milligrams, DAPT, and statin therapy. So I think that this publication really represents the concept that I want to get across today well. So this is an excellent paper that was recently published in Lancet by Scott Solomon's group. So in this paper, this is a cross-trial analysis that estimated treatment effects of essentially a regimen of contemporary therapy versus historical therapy. So contemporary therapy, the trial's Paradigm were used to represent ambulatory ARNI, DAPA-HF to represent ambulatory dapagliflozin use, and Emphasis HF to represent ambulatory aldactone use in heart failure, versus using the control group from Emphasis, which was one of historical type of medications, being beta blocker and ACE inhibitor and ARB. And This is the kind of the crux of the matter. So for our sample 55-year-old patient, by using a contemporary disease-modifying pharmacotherapy regimen, again, including an ARNI, beta blocker, MRA, and SGLT2 inhibitor, as opposed to just historical therapy with an ACE or ARB and a beta blocker, you're able to afford that 55-year-old an additional 6.3 years of survival on top of what they would have already gotten from an ACE inhibitor uh, uh, plus beta blocker sort of combination. So truly, that is the point. There is this misconception that once patients are ill, then we start thinking about improving the regimen, or maybe then we start thinking about changing to Entresto or adding an MRA or adding an SGLT2 inhibitor. But that is really the wrong concept. I mean, although we do that, I guess it's better late than never. But truly, the patient that you're going to be able to impact their natural trajectory the very most is the person sitting in your office who is doing well and telling you they feel great. That is who you can help the very most. I'm not saying that we don't still change and optimize therapy as people get sicker or older, et cetera, but truly, that well patient sitting in front of you, that is who gets the biggest bang for their buck and who is represented in these trials. Paradigm HF, for instance, I mean, this is a trial of essentially NYHA2 patients. So those are the people that we need to be introducing contemporary therapy and knowing that by doing that, we are going to, really impact the natural history of the disease and their survival. I hope that you all learned something today. I hope that through this presentation, you're able to gain new knowledge and take better care of our patients and treat heart failure like it's 2020. So thank you.